Hello, guys. This is a chapter summary for Braunwald's Heart Disease Textbook of Cardiovascular Medicine, 2018, on the chapter on Cardiooncology, chapter 81. We're going to skim through my highlighted areas. So, okay, in general, when we think about cardiotoxicity, we think of heart failure and left ventricular dysfunction. We usually don't think of the other adverse effects that may affect the cardiovascular system, not only the heart. So we have to take into account that for now, most of the evidence we have is on heart failure and left ventricular dysfunction, but we also have effects on blood pressure, which would manifest as hypertension. We can have manifestations on myocardial irrigation, which would lead to myocardial ischemia. We could have arrhythmias, pulmonary hypertension, pericardial disease, valvular disease, peripheral vascular disease, and thrombosis. So we have to take into account that as cancer patients are living longer, we will see more patients that are affected from the probable cardiotoxicities or the therapeutics which were used on these patients in order to treat their cancer. And as they live longer, the probability of seeing these effects in their lifespan or longer or further down the line is much larger. So we also have to take into account that cancer therapies are rapidly evolving. We have new options. And even though many of these options are trying to become targeted specifically for the cancer, we are seeing that there's always the possibility of cardiotoxicity. So this is an area that has to grow since it's the number of patients that are being affected by this, be it clinically or subclinically, are increasing. So that's why there's a chapter on this. So let's look at this table. It's a pretty nice table. I proceeded to underline each of the different agents in a specific color, and this is the color we will see on the text right next to this table. So remember, anthracyclines, they're first on the table, not coincidentally. It's because they are the ones that are most associated with cardiotoxicity. In general, anthracyclines. Which anthracyclines? Doxorubicin, daunorubicin, epirubicin, idarubicin, and metoxantrone. So all of these have very similar names. They finish in ubicin. Only mitoxantrone is a little different. So probably remember this additional name. I've never seen a patient with mitoxantrone treatment here in Costa Rica, but having in mind depending on where you are localized. So they are the ones which have the most evidence based on cardiotoxicity. Whenever you think of cardiotoxicity, you will probably first think of anthracyclines. You might also think of trastuzumab, which is a monoclonal antibody tyrosine kinase inhibitor. And after that, you'll think of other medications, but those will be the basis. So anthracyclines, which are the reported cardiotoxic effects? Cardiac arrhythmias, cardiomyopathy, and heart failure. The risk factors include the cumulative dose. We will see the dose in a while. Although genetic variation may confer increased risk at lower dosages, conventional cardiovascular risk factors, and disease. Additional cardiotoxic therapies, including radiotherapy or trastuzumab. Then we have the taxanes. I'm not sure how you pronounce that. Taxanes or taxanes. I think it's taxanes. Well, paclitaxel. You have, we will go into each of these in a while, but I'll just mention this through. And the cardiotoxic effects for taxanes are arrhythmias and myocardial ischemia. Comments: may exacerbate risk of anthracycline cardiotoxicity secondary to pharmacokinetic effects. Now, alkylating and alkylating-like agents. Okay, I'll make a parenthesis. Taxanes are the mechanism of action are they inhibit microtubule formation. So this is the way they affect the DNA synthesis. The alkylating and alkylating-like agents will help in the not creating this cross-linking of DNA. So these medications are related to my mnemonic, has to do with like this, anything that starts with ciclo. It's a Spanish mnemonic, so you Spanish speakers will probably get it. So the analogy is like if you were trying to cross a river, and in order to cross the river, you have what's this? And elevate a bridge. Through the bridge, you could pass, or you could cross the river with ciclo, which would be like a bike. Patín, cisplatin. Patín is patines, which patines mean roller skates. Carboplatin, platin again, roller skates. Patín, carboplatin, roller skates. There's another one that was called Carbo Mustang, I think, like a Mustang, a car crossing the bridge. Oxaliplatin, again, patin, platin, patin, roller skates. So that's like my mnemonic to remember which are the alkylating and alkylating-like agents, which will probably not function for English speakers. What are the effects? Cyclophosphamide, myopericarditis, and arrhythmias. For the others, for cisplatin, carboplatin, and oxaliplatin, you have endothelial dysfunction, arterial vasospasm, and hypertension. Comments for cyclophosphamide: it's rare. Cardiovascular complications reported only at high doses. So from here on, probably the probability of cardiotoxicity will be at least rarer than anthracyclines and the possible combination with trastuzumab and or radiotherapy. Now, antimetabolites, you have 5-fluorouracil and capecitabine. Reported effects. Okay, this one is, I associate this one more with ischemia. So if you have ischemia, you will probably have coronary vasospasm, some sort of vasospasm. You can associate those two. If you have myocardial ischemia, you could end up with an infarction. Other effects, arrhythmias, ECG changes. If you have ischemia, you can have ECG changes. And if you have an infarction, you could have a sudden death. Okay, so comments on antimetabolites may be related to endothelial injury, vasoconstriction, vasospasm, typically managed with nitrates and calcium channel blockers. So remember, you could use these medications to counteract the effects of the acute effects of the antimetabolites. Then we're going on to talk about monoclonal antibody tyrosine kinase inhibitors. First off, bevacizumab, which may produce hypertension, cardiomyopathy, heart failure, and thrombosis. It's low risk of cardiomyopathy or heart failure. Then you have trastuzumab. This one isn't low risk. This one is high risk. Remember, I mentioned it before we got here to this section. It may produce cardiomyopathy and heart failure. Comments: increased risk of cardiomyopathy and heart failure with anthracyclines. Hypertension, obesity, and borderline normal baseline left ventricular ejection fraction are also established risk factors. Many left ventricular ejection fraction declines are reversible, but in approximately 20% of patients, reversibility is not seen. And last but not least, we have pertuzumab, which can produce the same effects as trastuzumab, only that the risk for cardiomyopathy and heart failure remains incompletely defined, and for now is modest. So for this group of medications, trastuzumab is the one with the highest risk. Then we go on to talk about proteasome inhibitors. So these guys have to do with ubiquitin and the possibility of this large protein complex, the proteasome, is inhibited, and this may produce through bortezomib and carfilzomib. These guys end up in somib. Proteasome inhibitors finish in somib, may produce cardiomyopathy, heart failure, and edema. And let's see, the cardiotoxicity is probably greater for carfilzomib than for bortezomib. Then we pass on to small molecule tyrosine kinase inhibitors. Which ones are small molecule tyrosine kinase inhibitors? Sunitinib, it's first on the list for this group because it's the worst of them all. This is the one that has the highest risk than the others. So the others from the highest risk than the others of this group, which are small molecule tyrosine kinase inhibitors. Which are the effects? We have hypertension, cardiomyopathy, heart failure, thrombosis. Comments: risk of hypertension tends to occur early. Relationship between afterload and cardiomyopathy risk remains to be determined. Then we have sorafenib, which produces basically the same things, and we have that sorafenib has a risk of hypertension that is also associated with ischemia. Then we have imatinib, nilotinib, and the others. But here we add, with imatinib, we have the cardiomyopathy, we have edema, and we have pericardial effusion. Then we have, as a comment, the risk of cardiomyopathy is very low. Then we have linotinib, ponatinib, and dasatinib. These three guys are associated with peripheral vascular disease, ischemic heart disease, and dasatinib associated with pulmonary hypertension and pericardial effusion. Then we have this other group, which is immune-mediated agents, which would be thalidomide, lenalidomide, and immune checkpoint inhibitors. So immune modulating agents, those that end up in lidomide. Thalidomide, lenalidomide produce edema, thrombosis, and arrhythmias. And the immune checkpoint inhibitors produce myocarditis. Then we pass on to the androgen deprivation therapy, which would be leuprolide, goserelin, triptorelin, flutamide, and bicalutamide. So androgen deprivation, lights, no special association for mnemonics. And if they are altering our sex hormones, what do you think we'll find? We'll see alterations with metabolic syndrome, ischemia, coronary artery disease. Then we have the estrogen receptor modulators. Tamoxifen may produce thrombosis, and it has a favorable effect on lipids. Then we have the aromatase inhibitors, which are still part of the estrogen receptor modulators. And examples of them are anastrozole, letrozole, and exemestane. which produce hypercholesterolemia, hypertension, combined and endpoint dysrhythmia, valvular disease, and pericarditis. And last, the radiation therapy, which is associated with valvular disease, pericardial vascular ischemia, coronary artery disease, cardiomyopathy, and heart failure. Major cardiovascular events tend to occur late, although early abnormalities in cardiac function and perfusion are observed. So that's that table, which summarizes everything I'll basically talk about next. So let's go into a little detail with epidemiology, manifestations, pathophysiology. So the traditional chemotherapeutic agents, I already mentioned that anthracyclines are the most known for their cardiotoxicity, used since the 1950s, primarily manifested as heart failure and left ventricular dysfunction. Acute cardiotoxicity is rare, manifesting as arrhythmias, electrocardiogram changes, pericarditis, or even myocarditis and heart failure. Then we have the subacute. Subacute would be within 1 year. So subacute within 1 year, it's more frequent than the acute cardiotoxicity, and but isn't as frequent as chronic, which would be or late onset. Chronic or late onset would be after the year. After, or let's see, which would be after the year. And chronic would be after a year, and late onset would be occurred 10 to 20 years after therapy. So the most frequent seems to be chronic, which suggests a more frequent occurrence. Reported incidence in literature varies widely from 1.6 to 23%. Late onset would be after 10 years in the setting of a second hit. Recent data say that overall incidence of cardiotoxicity, defined as a decrease in LV ejection fraction of more than 10% from baseline to less than 50%, was 9%, so pretty frequent. In 98%, it was detected within the first year. So most cases were detected subacutely before the year because let's see, the chronic was after the year. The median time around 3.5 months. A very small number of patients were hospitalized. Heart failure therapy was initiated in all patients who developed cardiotoxicity, and 82% presented recovery. These findings overall suggest a need for increased screening after completion of chemo and challenge the notion of irreversible left ventricular ejection fraction declines with early pharmacologic intervention. Risk factors include dosage. Cumulative dose of more than 300 milligrams per meter squared gives you a risk of 4.7% incidence of heart failure, which, the cutoff would be probably 250 to 300 milligrams per meter squared, but we'll figure that out in a moment. Additional risk factors would be age, traditional cardiovascular risk factors such as hypertension, diabetes, obesity, and hyperlipidemia, presence of coronary artery disease or cardiomyopathy, prior chest radiotherapy, or additional cardiotoxic therapy. Now we have figure 81.1 showing us the risk of doxo-associated heart failure by patient age and cumulative dose. So as we age, the more we age, the worse for cardiotoxicity, and the more dose we get, also the worse for the possibility of cardiotoxicity. What are the mechanisms for this toxicity? Reactive oxygen species and increased oxidative stress, main reason. Then we have other things like impaired calcium signaling and intracellular sequestration. The most widely cited and accepted is the formation of reactive oxygen species. Then we have toxic hydroxyl radicals from anthracycline iron complexes act as cytotoxic messengers. This results in impaired mitochondrial function, cellular membrane damage, and cytotoxicity. Nitric oxides synthase also contributes to the generation of nitrogen species. And here we can see the figure 81.2 showing the proposed mechanisms of anthracycline cardiotoxicity. So let's start off where it says anthracyclines, that lower right. We have calcium overload. This produces degradation of the sarcomere and titin, resulting in diastolic dysfunction. We have DNA damage through topoisomerase 2 beta, producing reactive oxygen species, which take on to lipid peroxidation and membrane damage, mitochondrial dysfunction, P38 MAP kinase alterations, and impaired stress response, and reduction in cardiac progenitor cells. So here you can see the different mechanisms and how each will contribute. We also have that anthracyclines stop the hypoxia inducible factor pathway, and this ends up generating altered energy metabolism. Then we have that mice that lack this topoisomerase 2 beta are protected from anthracycline-induced DNA damage, and that dexrazoxane, an iron chelator and cardioprotectant, binds to the topoisomerase 2 beta and results in its degradation, and it's better for the patient. Then we have the NRG1, which it has shown that administration is cardioprotective in the setting of anthracycline-induced cardiotoxicity. Anthracyclines have been shown to result in impaired diastolic relaxation via calpain-dependent titin proteolysis. That's it for anthracyclines. Now, taxanes. Paclitaxel or Taxol and its semi-synthetic analog docetaxel or Taxotere disrupt microtubular networks. Used alone, it has little cardiotoxicity. It manifests as asymptomatic bradycardia and AV block. However, combination with high-dose doxorubicin produce heart failure in 21% of patients. Secondary to alterations in doxorubicin metabolism, limiting the doxo and separating infusion time produce substantial decrease in their risk. Now, passing on to alkylating and alkylating-like agents. Cyclophosphamide typically well tolerated, but dosages greater than 100 milligrams per kilogram produce case reports of hemorrhagic myocarditis, tachyarrhythmias, heart failure, pericardial disease. Then we have the platinum-based alkylating-like agents. So the only alkylating, real alkylating would be cyclophosphamide, and the alkylating-like platinum-based are commonly used in germ cell testicular cancer. 5.7-fold increased risk of coronary artery disease and 2.3-fold risk of atherosclerotic disease as defined by coronary disease, cerebrovascular, and peripheral artery disease. It's associated with endothelial damage because plasma platinum levels remain detectable in patients up to 20 years after therapeutic exposure. Then we have the antimetabolites. 5-fluorouracil used in many solid tumors, including gastrointestinal, breast, head, neck, and pancreatic. Specific cardiovascular effects are myocardial ischemia, which is the most common, as arrhythmias, hypotension, cardiomyopathy, and cardiac arrest. Then we have endothelial injury, vasospasm, vasoconstriction, and interstitial fibrosis. 8.5% had symptoms of cardiotoxicity, presenting primarily as angina and electrocardiographic changes. These symptoms often are treatable with nitrates and calcium channel blockers, have historically been attributed to vasospasm. The oral agent capecitabine, 6.5% incidence of cardiac events. Additional cancer therapies, we have proteasome inhibitors, bortezomib and carfilzomib, used in refractory and newly diagnosed myeloma. Cancer cells generally have higher levels of proteasome activity compared with normal cells, and thus are believed to be particularly susceptible to the pro-apoptotic effects of proteasome inhibitors. Both bortezomib and carfilzomib have an incidence of heart failure 4 and 7% respectively. Carfilzomib is greater than bortezomib. Additional cardiotoxicities also been observed. Immune modulating agents, thalidomide and lenalidomide, used in myeloma, risk of venous thromboembolic events in the order of 2 to 4%. Incidence increases in combination with dexamethasone or anthracyclines. To mitigate, use aspirin, low molecular weight heparin, or warfarin with combination therapy. Immune checkpoint inhibitors, very low, but clinically significant risk of myocarditis, with both anti-CTLA-4 and anti-PD-1 antibodies. Targeted therapies. It was hoped that this approach would reduce toxicities typical of standard chemotherapies, but concerns about cardiotoxicity have surfaced for several agents. So these targeted therapies, we have ERB-B antagonist as trastuzumab, pertuzumab, and T-DM1. Trastuzumab binds to HER2-neu, also known as ERB-B2, blocking HER2 cleavage, resulting in inhibition of HER2-mediated signaling, affecting the different pathways P13 kinase, AKT, MAP kinase, ERK1/2, and mTOR. It was approved by the FDA in 1998 for advanced metastatic cancer and for breast cancer in 2007. Risk of severe heart failure is low, but declines in left ventricular ejection fraction are greater, on the order of 7 to 18.6%. As a result, monitoring every 3 months during trastuzumab therapy, every 3 months for trastuzumab. However, retrospective analysis from various large data sources indicate that the incidence of heart failure and cardiomyopathy development may be higher. As with anthracycline cardiotoxicity, hospital-based heart failure events occur less frequently, but patients treated with sequential anthracyclines and trastuzumab therapy are observed to have an increased risk hazard ratio 3.96. As with trastuzumab alone, hazard ratio of 1.76. The risk is greatest in sequential anthracycline and trastuzumab and additional risk factors. LV ejection fraction declines are largely reversible and initially termed type 2 dysfunction, which has fallen out of favor because of its oversimplification. The clinical determinants of LV recovery in observations suggest temporary cessation of therapy and/or institution of cardiac medications associated with recovery. Changes in cardiac size and function suggest that measures of LV size, contractility, and afterload are independently associated with left ventricular ejection fraction decline and recovery. Mice with a cardiac-specific deletion of ERB-B2 develop dilated cardiomyopathy and demonstrate exaggerated systolic dysfunction after pressure overload. So let's see, systolic. Mice with a cardiac-specific deletion of ERB-B2 develop dilated cardiomyopathy and demonstrate exaggerated systolic dysfunction. Okay, so This mechanism of action for trastuzumab definitely in vitro and in mice seems to affect. ERB-B2 and ERB-B4 expression is preserved during compensated hypertrophy, but it declines in the early stages of systolic dysfunction. Disruption of ERB-B2 signaling results in endothelial dysfunction and an altered vascular phenotype, potentially contributing to the cardiomyopathic phenotype. So here we have a figure with proposed mechanisms of trastuzumab cardiotoxicity. Important things to take into account are the neuregulin NRG slash ERB-B signaling pathway. So trastuzumab affects this neuregulin ERB-B signaling pathway, which results in inhibition of fundamental cardiovascular signaling pathways responsible for cell growth, structure, survival, and angiogenesis. Pertuzumab, which is a humanized monoclonal antibody that binds HER2, administered in conjunction with trastuzumab. It also stimulates antibody-dependent cell-mediated cytotoxicity and prevents dimerization to other ligand-activated HER receptors, especially HER3. Data to date have not substantially demonstrated cardiotoxic signal. It was largely reversible in most patients, but not all, whatever we saw for pertuzumab. Then we have trastuzumab emtansine, which is TDM1. It's an antibody-drug conjugate used in the treatment of metastatic breast cancer, and we need more data to know about its cardiotoxicity. Then passing on to tyrosine kinase inhibitors and monoclonal antibodies. In leukemias and cancers, the gene encoding the causal or contributory tyrosine kinase is amplified, leading to overexpression, or mutated, leading to a constitutively activated state. Then it doesn't mention much else about these. We already have it on the table. Vascular endothelial growth factor receptor inhibitors are used in metastatic renal cell cancer, gastrointestinal stromal tumors, and thyroid, hepatocellular, and colon cancers. Bevacizumab is a humanized anti-VEGF antibody. Cardiovascular risks are hypertension mainly, and low incidence of heart failure, and increased incidence of arterial thromboembolic events. 7.1% of bevacizumab versus chemo alone. Then the sorafenib blocks also VEGFR and also PDGFR, or platelet-derived growth factor, and also RAF, which is rapidly accelerated fibrosarcoma. It is used in metastatic renal cell, thyroid, and hepatocellular cancers and other solid tumors associated with cardiac ischemia and hypertension. Both of these, bevacizumab and sorafenib, have less pronounced cardiotoxicity effects than sunitinib. Sunitinib is a multi-targeted oral tyrosine kinase inhibitor in metastatic renal cell, gastrointestinal stromal tumors, and neuroendocrine tumors. Okay, let's see what else. Of these agents, we focus on mainly on sunitinib because it is the most well studied. So what else does it say about sunitinib, which results in hypertension as well as declines in LV ejection fraction? LV dysfunction, defined by declines in LV ejection fraction, is in the order of 10%. Early after the initiation of therapy, primarily within the first 3 months. Then we have the BCR Abel targeted therapies. Imatinib, the first targeted small molecule tyrosine kinase inhibitor of the fusion protein BCR Abel, which arises from the chromosomal translocation created in the Philadelphia chromosome, revolutionized the treatment of chronic myeloid leukemia. Dasatinib, with more potent activity than imatinib, associated with significant pulmonary hypertension. nilotinib associated with cardiometabolic effects. Deciphering the mechanism of these kinase inhibitors remains challenging given their non-selectivity. They typically affect more than 30 different kinases. Hormone therapy or androgen deprivation therapy now is used to reduce levels of androgens in circulation and decrease prostate cell growth, including GnRH agonists such as leuprolide, goserelin, and triptorelin, and anti-androgens such as flutamide and bicalutamide have adverse metabolic effects, suggest that they result in increased body weight, decreased insulin sensitivity, and dyslipidemia. Increased risk of cardiovascular events in men, including coronary disease, myocardial infarction, sudden cardiac death, or death due to cardiovascular disease. Then we have selective estrogen receptor modulators and aromatase inhibitors. Tamoxifen is selective estrogen receptor modulator widely used in adjuvant therapy for estrogen receptor positive breast cancer. A favorable effect on lipids, but a potential effect on decreasing decreasing ischemic heart disease. Although it has this potential effect, it has an increased risk of thromboembolic events well established. They largely occur during the first 2 years. Now, aromatase inhibitors as an anastrozole, letrozole, exemestane block the conversion of androgens to estrogen, associated with worse hypercholesterolemia and hypertension, and modestly increased risk of cardiovascular disease as defined by myocardial infarction, angina, or heart failure with aromatase inhibitors compared with tamoxifen. Recent retrospective analysis determined they were not associated. However, combined outcome of dysrhythmia, valvular dysfunction, and pericarditis. Okay, honestly. Yeah, so these aromatase inhibitors were not associated with an increased risk of cardiac ischemia or stroke, but they were, however, with dysrhythmia, valvular dysfunction, and pericarditis. Now, radiation therapy. Cardiotoxicity includes coronary disease, cardiomyopathy, heart failure, valvular arrhythmia, and pericardial. In a meta-analysis of over 23,000 excess of deaths as early as 5 years following radiotherapy, principally due to cardiovascular disease and lung cancer. Retrospective analysis of 4,456 women shows 1.76-fold increased risk of cardiac mortality and 1.33 risk of vascular mortality. Left-sided disease had a 1.56-fold increased risk compared with right-sided. SEER study confirmed left-sided versus right-sided disease. Cardiovascular events increased linearly by 7.4% for each gray increase in mean radiotherapy dose to the heart, 7.4% linearly for every gray. Similar studies in Hodgkin lymphoma survivors corroborate an association between the radiotherapy dose to the heart and the risk of cardiovascular disease. Risk of cardiovascular complications 3 to 5-fold. Cumulative incidence of cardiovascular disease increased from 2.2% at 5 years to 16% at 20 years. Cumulative radiotherapy dose. Additional risk factors include radiation field, younger age, concomitant chemo, cardiovascular risk factors. Valvular disease with leaflet thickening, fibrosis, and calcification. Left-sided, more particularly the aortic valve, followed by mitral tricuspid valves. Sparing of the mitral valve tips might help distinguish from rheumatic heart disease. Regurgitation is more commonly with the exception of the aortic valve disease, which in the aorta, it mainly manifests as stenosis, and the rest of them as regurgitation. Pathophysiology of valvulopathy would be increase in TGF beta and osteogenic factors, including bone morphogenetic protein 2, osteopontin, and alk-phos. Radiotherapy is also associated with the development of heart failure and cardiomyopathy, diffuse myocardial fibrosis, and systolic diastolic dysfunction, also restrictive. Increase in disease in the LAD also may produce autonomic dysfunction, elevated resting heart rate, and abnormal heart rate recovery. Also may affect the pericardium with effusions, thickening, and constrictive. Now, the cardiovascular care of the cancer patient. Remember, this is a continuum. First, we see the patient before presentation. We identify risk factors and treat them. Then, during cancer therapy, we monitor to identify for cardiotoxicity, avoid dose interruptions, safe delivery of cancer therapy, and prevent cardiovascular events. After cancer therapy, we check their risk factors and follow them up and check if they need some treatment, heart failure treatment, or treatment against the the dysfunction or alteration. Now, prevention and monitoring of cardiac dysfunction. Guideline, question 1. Which cancer patients are at increased risk? So, those patients with high-dose anthracyclines, which would be for doxorubicin more or equal to 250 milligrams per meter squared, and epirubicin would be 600 milligrams per meter squared. Then we have high-dose radiotherapy, which would be more or equal to 30 grays. Then we have lower dose anthracyclines, which would be less than 254 doxo and 600 for epi, plus lower dose radiotherapy or less than 30 grays. Then we have trastuzumab, treatment with lower dose anthracyclines or trastuzumab alone, plus the following risk factors, which would be multiple, more or equal to 2 cardiovascular risk factors. Other is older, more or equal to 60 years age at cancer treatment. Another one is a LV ejection fraction 50 to 55%, history of myocardial infarction, moderate or more severe valvular heart disease. Treatment, another criteria is treatment with lower dose anthracyclines, followed by trastuzumab or sequential therapy. The evidence for this evidence quality is intermediate, strength is moderate. So now no recommendation can be made on, this is recommendation 1.2. So it says no recommendation can be made on lower dose anthracycline or trastuzumab alone, and no additional risk factors. Next is kinase inhibitors.
Just a sec.
Let's see if Siri was reading some. Low dose
Stand by, please.
Radiotherapy and no additional cardiotoxic therapeutic exposures or risk factors.
Working on that.
The last one is kinase inhibitors. Okay, you can't recommend anything special on those patients.
Sorry, I'm having trouble with the connection. Please try again in a moment.
Evidence-based low. Guideline question 2. Which preventive strategies minimize the risk prior to initiation of therapy? Then one is avoidance, to minimize use of potentially cardiotoxic therapies if established alternatives, obviously. A comprehensive assessment, screening, and an echocardiogram, obviously. Which preventive strategies are effective in minimizing the risk during the administration? We have actively managed modifiable cardiovascular risk factors. Evidence of quality is insufficient. the strength of recommendation is moderate. Then we have dexrazoxane or continuous infusion or liposomal formulation of doxorubicin for prevention of cardiotoxicity in anthracyclines, in high-dose anthracyclines. Evidence intermediate strength moderate. 3.3, lower radiation, more precise or tailored through use of advanced techniques as deep inspiration breath holding for patients with mediastinal tumors or breast, intensity modulated radiation therapy that varies the radiation energy while treatment is delivered in order to precisely contour the desired radiation distribution. Evidence quality intermediate, recommendation is strong. Question 4, what is the preferred surveillance or monitoring approaches during treatment? Complete a careful history and physicals, that's strong. Signs or symptoms concerning for cardiac dysfunction during assessment, recommend echocardiogram. Evidence intermediate strength is strong. Muga scan if an echocardiogram is not available or technically feasible. With preference given to cardiac MRI. Evidence is intermediate, recommendation is strong. No, intermediate and moderate. Then serum biomarkers or strain in conjunction with routine diagnostic imaging. Evidence intermediate and strength of recommendation is moderate. Referral to a cardiologist based on findings. Evidence insufficient, not sufficient, and recommendation is strong. Now, routine surveillance in asymptomatic to be at increased risk, do an echo, which would be the modality of choice. Evidence is intermediate, recommendation is moderate. No recommendations can be made regarding continuation or discontinuation of cancer therapy in individuals with evidence of cardiac dysfunction. Should be considering the risks and benefits. Evidence is insufficient. Clinicians may use routine echo surveillance in patients with metastatic breast cancer, continuing to receive trastuzumab indefinitely. Frequency. Frequency should be determined. There's evidence de tampoco. Clinical judgment. Question 5, what are the preferred surveillance and monitoring approaches after treatment in patients at risk for cardiac dysfunction? Careful history and physical, obviously. Signs or symptoms concerning for cardiac dysfunction should be offered echo, strong, same as the others, MRI or MOGA with preference to MRI, that's moderate. Serum biomarkers, moderate. Referral to cardiologist, moderate. Recommendation 5.2, between 6 and 12 months after completion. In asymptomatic patients considered to be increased risk, you should do an echo. Evidence moderate. Cardiac MRI or MUGA may be offered if an echo is not available or technically feasible. Moderate. Asymptomatic cardiac dysfunction should be referred. Evidence strong. No recommendations on asymptomatic and have no evidence of cardiac dysfunction under 6 to 12 month post-treatment. Evidence insufficient. Clinicians should regularly evaluate and manage cardiovascular risk. Moderate. Identifying cancer patients at risk. Briefly, these include high-dose anthracyclines, high-dose chest radiotherapy, a combination of lower doses of anthracyclines and chest radiotherapy, cardiovascular risk factors, including tobacco use, hypertension, diabetes, dyslipidemia, older age, and a history of cardiovascular disease, a borderline low left ventricular ejection fraction, 50 to 55%, and a greater than moderate valvular disease. No validated clinical risk prediction algorithms. Genetics implicate polymorphisms, CBR and HSAS3, which might be independent modifiers. Other things associated with cardiotoxicity, SLC28A3, SLC28A1, a lot of different genes, but for now, a couple of genes have been demonstrated. CBR, HAS, SLC, the causal roles of genes remains an area of active investigation. So we don't know shit yet about what's their role in cardiotoxicity. And we actually cannot test for these gene modifications in our country. So senseless for now. Biomarkers hold promise as aids, but they are not yet recommended routinely. LV ejection fraction is associated with subsequent cardiotoxicity in studies. Longitudinal strain with a focus on evaluating the change over time is important. Abnormalities reflect an inherent vulnerability to cardiac dysfunction. Now, cardiovascular care of the patient during therapy. Cardiac troponins are sensitive and specific markers for myocardial injury. In cardiooncology, troponin is the most widely studied. Highest cardiotoxicity event rate among patients with early or within 72 hours troponin I elevation more than 0.08 that persisted at 1 month after treatment. Associated with a lack of LV ejection fraction recovery despite heart failure therapy. Validation is an area of active investigation. Then we have the BNP and NT-proBNP. Conclusions regarding the role, prediction, and diagnosis of cancer therapy cardiotoxicity remain conflicting. The 2016 European Society of Cardiology said that they may be considered. Moreover, the group noted that data are still needed to validate use of these biomarkers. The ASCO guidelines suggested that cardiac biomarkers used in conjunction with routine diagnostic imaging. So the ASCO guidelines recommend more strongly than the 2016 European Society of Cardiology recommendations. So there's also newer biomarkers which might have a role in risk prediction as MPO, ADMA, immunoglobulin E. As it pertains to the application of imaging tools, there are many small studies. Diastolic dysfunction have not been shown to be strongly predictive of systolic dysfunction. Longitudinal strain demonstrated promise as a measure of subclinical cardiotoxicity. Circumferential strain also associated with subsequent LV ejection fraction decline with moderate discriminative ability. The ACE recommended GLS for the early detection with a particular focus on change over time. This is an area of active research. CMR is accurate and reproducible LV size and function. An active body of research is evaluating the use of relaxation times for CMR. Now, cardioprotective strategies before and during therapy. An agent specific to the mechanisms of anthracyclines, which would be dexrazoxane, a derivative of the chelating agent ethylene diamine tetraacetic acid, ethylene diamine tetraacetic acid, EDTA, ethylene diamine tetraacetic, what the fuck, prophylactic strategy, although it is not currently approved by the FDA. Cardioprotective effects via a number of mechanisms. It prevents ROS generation. It inhibits the topoisomerase 2 beta. Its use has been limited by concerns over an increased risk of subsequent hematologic malignancies. So, you're giving the patient dexrazoxane in order to stop the cardiotoxicity, and you're getting hematologic malignancies. It doesn't make much sense, including acute myeloid leukemia and myelodysplastic syndromes. There are numerous ongoing studies evaluating the potential cardioprotective prophylactic effects of conventional heart failure and cardiovascular pharmacologic therapies. Limitations of these studies include small sample size, lack of a consensus on the definition of a clinically relevant cardiotoxicity outcome, and lack of generalizability. No expert consensus group currently recommends the use of prophylactic therapy without another cardiovascular indication. So, for example, if you have a diabetic patient with hypertension, you could give him an ACE inhibitor. If you're just following this patient, has no other cardiovascular risk factor, so there's no consensus on prophylactic therapy if the patient hasn't presented the cardiotoxicity. The potential cardioprotective effect of non-pharmacologic therapies such as exercise and diet modification are also under active investigation. Now, cardiovascular care of cancer survivors. Although the appropriateness of screening in survivors is widely accepted, recently been called into question given concerns about overutilization and cost effectiveness. Most episodes of cardiotoxicity occur within the first year. Table 81.2 talks about children's oncology group recommendations for cardiac monitoring. So, what do we have to think about? We're going to think about on the y-axis, if the age of the patient, less than 1 year, or 1 to 4 years, or more than 5 years. And on the x-axis, we'll have irradiation with potential impact to the heart, yes or no, the anthracycline dosage, and recommended frequency of echocardiogram or MUGA scan. So we have, depending on these, we will give recommendations to assess every 5 years, every 2 years, or every year. Which patients could I assess every 5 years? Every 5 years could be a patient which is older than 5 and has a dosage of less than 200 milligrams per meter squared without irradiation with the heart being involved. Another patient that I could assess every 5 years, a patient 1 to 4 years old with the lowest dose for doxorubicin less than 100 milligrams per meter squared without having the heart irradiated. And now let's pass on to talk about those causes that require every 2 years would be the gray area. Whenever you have, if there's irradiation to the heart, one of two. If you have irradiation to the heart with a low doxorubicin dose, every 2 years at least. Or if you have the higher range anthracycline dose without impact to the heart, without irradiation, every 2 years. But if you have both of these, if you have heart involved with irradiation and higher anthracycline dosage, you have to see this patient every year. There's a recent data from St. Jude lifetime cohort study of 1,820 adult survivors of childhood cancer exposed to anthracycline chemo or chest-directed radiotherapy or both, suggesting high prevalence of subclinical dysfunction with abnormal global longitudinal strain 8% and diastolic dysfunction 9.7%, despite normal LV ejection fraction. So what are risk factors? Male sex, anthracycline dosages more than 250 milligrams per meter squared or higher, cardiac radiation exposure of more than 1,500 centigrades, and hypertension associated with increased risk for cardiomyopathy. And randomized clinical trials examining therapies specifically in cancer patients with cardiomyopathy have not yet been performed. And as such, effectiveness of certain medications, cardiovascular medications over others in this patient population remains largely unknown, as does the optimal duration. So in general, for the future perspectives, this topic needs a dedicated cardiovascular care. You need to call, it calls to one, advance our understanding of basic pathophysiology. Two, translate these new learnings or findings to improve care. Three, understand the epidemiology and natural history of cardiotoxicity. Four, identify high-risk cardiovascular patients. Five, personalize the delivery of therapy to maximize its oncologic effectiveness and minimize its cardiotoxic potential. That's it for this summary. I made this summary for me, and I do not think I will share this summary because I just had lunch and was a little sleepy, and it's not the best there is. I did it pretty swiftly, had a little trouble amongst not falling asleep, maintaining attention, and finishing this up. So that would be it. Thank you.